Thank you, Bala, very much. Your intentions are very clear from day one, because I can see in the whole of the program there is only one pro-con session, and that is between the two of us. So that is one thing. And the second intelligent thing which he has done is he has put me with my very, very superior person in obstetric anesthesia. So I stand here as a meek fellow, an intimidated fellow who knows a little bit about obstetric anesthesia, and I'm supposed to debate with a doyen of OB anesthesia. So you can imagine the state of affairs. I think Bala is taking it out on me. So I thought, how am I going to counteract this difficult situation? We always sit together and then we are not debating on a common topic.
Kajal, I did this because you didn't do my night duty one day in PGI.
But so then I thought, okay, just chill out. Just remember the rule, go back to the history and remember there is a rule which says boss is always right. And the rule number 2 is, if the boss is wrong, see rule number 1. So I start this debate with already hands down. We go ahead with whatever madam says at the end of the story. So here we go. So we all know that spinal anesthesia for C-section is a very, very popular technique. We all like to do it because it is simple, safe, and effective. So having said that, we should also remember it should also be safe for the baby as well, both mother and the baby. And incidence of maternal spinal hypotension is pretty big as compared to the non-obstetric counterparts. It is 55 to 90%. We don't like it because it causes a lot of intraoperative nausea, vomiting to the mother, and rarely it will contribute to a cardiovascular collapse, but more importantly, it causes a decrease in uteroplacental blood flow, which is not desirable, and consequently, it may also cause fetal acidosis. So these are the things we have to keep in mind whenever we are doing this simple and safe anesthetic technique. So historically speaking, we have a wide spectrum to choose from, and we have been using various drugs which are available to us, like mefentremine is a very popularly used drug. But again, these drugs do bring up the blood pressure, but they also have a very potent vasoconstrictor effect, and they play havoc with uteroplacental blood flow. They do not allow the baby to get a good blood flow, so we don't like to use them. So basically, the first 3 are out. So what are remaining is ephedrine and phenylephrine. So if ephedrine had historically enjoyed the gold standard crown for a very, very long time, till early 2000s. So ephedrine was the drug because researchers found that this drug does not have any deleterious effects on the uteroplacental blood flow. So basically, any drug which is friendly with the uteroplacental bed is good for us. And this came from this landmark study very, very early in 1974. It saw to it that the uterine blood flow in pregnant Eves was not affected when we use ephedrine. So ephedrine really stayed the queen of obstetric vasopressor for a long time. But then everything doesn't happen like that. Soon there were some people who were finding out ways to see what is wrong with this ephedrine, and they found that ephedrine crosses the placenta to a greater percentage and undergoes less early metabolism as compared to phenylephrine. That means it stays in the placental bed for a longer time, induces fetal metabolic activity, and therefore causes fetal acidosis. So this was one study which was done in 2009, and following this, we started wondering that, do we really like this drug? Then soon enough, there was a meta-analysis which was conducted, a systematic quantitative systematic review, which clearly highlighted that we should not be using ephedrine because it causes fetal acidosis. So other drawbacks to ephedrine, apart from fetal metabolic activity, included it's difficult to titrate to a goal blood pressure, and because it had a delayed onset and a long duration of action. It had a lower efficacy because larger doses were required to bring up maternal blood pressure. Since we were using too higher dose, it caused acute tolerance contributing to tachyphylaxis. So this was not a good drug. So practice guidelines for obstetric anesthesia also came up looking up the literature, and they said that we should start using phenylephrine as an acceptable alternative to treat maternal hypotension. That is how phenylephrine started coming to us. So why phenylephrine? Researchers saw through the next decade of research that phenylephrine was very effective. It was a good alpha agonist, a potent vasoconstrictor with a fast onset, short duration, easy titrability, and low incidence of fetal acidosis. So phenylephrine scored very high on these aspects. So let us see what the literature has to say to support all these points. So this was one landmark study by the researchers Nanki et al., and they have been the pioneers in changing the face of obstetric vasopressor. The paradigm shift has been brought about by them. And in this study, they said that if you use phenylephrine and if you target the maternal baseline blood pressures, you give a very good outcome to the mother, in the sense the mother doesn't vomit and the mother is able to bring up her blood pressures very fast. And on top of that, the acidosis part is gone. So this was one landmark study which changed the face of everything. So they finally opined that phenylephrine infusion is a simple, safe and effective method for maintaining blood pressures. So later on, after seeing so many randomized trials, a systematic review came up in 2014, which included 21 randomized trials with approximately data from 15,004 patients. And they also said that there's a decreased incidence of hypotension before and after delivery if you use phenylephrine infusion. So who wouldn't like to use it? So it's such a good drug, and it gives a very good effect and brings up the blood pressure in no time. So then another meta-analysis came up to look at the incidence of fetal acidosis as compared to ephedrine. And this study, meta-analysis informed us that there was a decreased relative risk of fetal acidosis as compared to ephedrine to the tune of 5.29 with ephedrine. So this is a big factor which allowed us to use phenylephrine even more prominently in our clinical practice. So then another study came up, this is again in 2008 by the same group, Nanki et al., and here they tried to use it in non-elective cesarean sections. The earlier studies were done in all elective patients, low-risk parturian, where the fetal acidosis did not really contribute to a clinical outcome. All the babies were having a good UPGAR. So now he says, let's see what happens in a non-elective cesarean section. And here he found out that the mothers vomited more with ephedrine as compared to phenylephrine. And this may be because phenylephrine takes care of blood pressure faster than ephedrine. So basically, there is decreased intraoperative nausea and vomiting, so you should be using phenylephrine. So 2 studies were then again done in cases of acute fetal compromise, one done from my center and another one was done from Delhi. Both the studies come from India for a change. And both the studies found lower incidence of maternal nausea and vomiting with phenylephrine with no effect on fetal acidosis in patients having acute fetal compromise. So basically, we have to remember that whenever we are talking about maternal hypotension, we should treat the cause and not the symptom. And lately, there has been a thought of change that unlike the previous notion that it was all because of aortic gravid uterus pressing over the aortic cable and venous capacitance dilating, there is also loss of arteriolar tone. And this arteriolar dilatation is the major factor leading to hypotension. Vasopressors are therefore the mainstay for managing spinal induced hypotension, and there is nothing better than phenylephrine. So what about the newer agents? I'm sure Madam is going to tell you something new because that's how it is going to be. So the new drug which is coming up in the market is norepinephrine. I mean, it's an old drug, but it is going to be used for maternal hypotension, already undergoing trials, but we do not have substantial data to support the use of noradrenaline as of now. So we have a weight of evidence for phenylephrine versus burden of proof for noradrenaline at the current times. So let us see how Madam is going to convince us to use noradrenaline versus phenylephrine versus ephedrine. Thank you very much.
Madam, we have never seen you ferocious. You are always smiling, so once we would wanted you to be a bit ferocious, madam.
Well, Dr. Bala, I sincerely hoped you would have kept 2 boxing gloves here to give us all the audience a feel of this pro-con session, you know. So we have heard Dr. Kajal trying to defend phenylephrine and let's see how we can break this myth. And I hope the audience will be with me on this. Isn't that a beautiful picture?
Madam, today in banquet, 10 minutes is allotted for this, madam.
Great. You arrange for our boxing gloves, you promise. Okay, so I want the audience to tell me a poll. How many of you use mephentermine? Yeah, maybe about, wow. About, I think, 40% of them. And how many of you use ephedrine? 40. And how many use phenylephrine? Wow, just about 20 of them. So I think the debate is over. Okay, let's look at what phenylephrine does. Just to summarize what Madam told us, it does cause vasoconstriction, and this leads to an increase in the systemic vascular resistance, and of course it maintains the blood pressure, right? Very good enough for Madam, but this vasoconstriction also causes an increase in the afterload, and theoretically this decreases the cardiac output. So are we concerned about the cardiac output? What should I aim at? All the literature says that we should keep our blood pressure 100% at baseline. So then, is there a place for keeping the cardiac output at normal values? Look at this literature. It says that blood pressure is a key driver of flow through low resistance, uteroplacental circulation, but the cardiac output is equally important because it is an important component of the oxygen delivery, and specifically it is more important in situations where you face fetal asphyxia. So this interesting article from Dyer et al., where they looked at the cardiac output by non-invasive techniques, they used pulse waveform analysis and a bioimpedance, thoracic bioimpedance. And what they came up with was that in comparison to ephedrine, when they looked at the pre-vasopressor values and compared it with the post-vasopressor values, they found that the cardiac output increased by 5% with ephedrine, but it decreased by 14% with phenylephrine. And that was directly related to the bradycardia effect of phenylephrine, which is considered a surrogate marker for the decrease in cardiac output. Another interesting review article which comes from Ashraf Habib, he looked at the maternal and neonatal outcomes and also the maternal hemodynamics following cesarean section. And he says that bradycardia is a significant effect that occurs with phenylephrine when you're giving prophylactic infusions. And if bradycardia occurs, if it's significant, you need to stop the drug. And if it is not accompanied by hypotension, and if you give an anticholinergic drug, you will land up with significant hypertension. This is what we do not want in a compromised fetus. Now, phenylephrine, again, apart from having a decrease in cardiac output, it also causes dysrhythmia, specifically ventricular tachycardia, supraventricular tachycardia, coronary artery spasm, and MI. Any other drug you remember which causes significant effects like this? Are oxytocin, which we regularly use. So it may have a compounding effect, and that is a major concern for obstetricians here. An interesting editorial by Butwick recently in 2015, and he commented upon the drugs which are being used for preventing spinal hypotension during cesarean section, and he says that phenylephrine infusions on maternal cardiac output indices and neonatal outcomes in women with altered vascular reactivity, preeclampsia, compromised cardiac function, or a non-reassuring fetal status who require emergency cesarean sections are not well elucidated. So it is also a gray zone at present. There is no consensus regarding use of it there. Now, a lot of articles have talked about the importance of giving prophylactic infusions of phenylephrine as compared to the bolus dose. They the incidence, like Madam said, the advantages of giving a prophylactic infusion, you'll find that when it is compared with a manual bolus dose, the incidence of hypotension is much less, hypertension is much less, and the incidence of nausea is much less. So the bottom line is, when you give phenylephrine, it should always be a prophylactic infusion. So then how do you give an infusion? Because once bradycardia occurs, you need to stop that infusion. So you need to have ephedrine along with it. So you need 2 of these infusion pumps. You need a cardiac output monitor, and you need a computer algorithm. So this setup has been hailed as the new technology closed loop feedback system that provides a solution to limit the gap between monitoring and drug delivery. So I do not want to talk about the expenses involved here. But Madam comes from PGI, so maybe these factors do not bother her. So then a fight starts between norepinephrine and phenylephrine. Regarding ephedrine, I agree with Madam. It's a no-no, especially in situations where there's a compromised fetus, and also as such, ephedrine is out of the picture now. Now norepinephrine versus phenylephrine, there is no difference in the blood pressure and no difference in the IONV, a higher cardiac output and a higher heart rate means there is no bradycardia, and even the umbilical vein pH and oxygen content are higher with norepinephrine. So Brendan Carvalho in his recent editorial says that is there another paradigm shift which is in the offing. He says that the blood pressure is well maintained and there is less bradycardia and less decrease in cardiac output, and that is what we want in a compromised fetus. So this article published in 2017 again reiterates this, and that it says that it can norepinephrine can be considered a very good alternative to phenylephrine. This interesting article, we had been talking about prophylactic infusions, the problems associated with these infusions, but this recent article, which is going to be published in July 2017, it says that you do not need to give prophylactic infusions of norepinephrine. You can just make do with 6 microgram of a bolus dose of norepinephrine. So you do not have to go in for serial dilutions here. And Niganki, who started all this controversy about ephedrine and norepinephrine, he has gone, ephedrine and phenylephrine, he has gone on to advocate the use of norepinephrine. And he says that much lower dilutions are required at 6 mics per ml as compared to 100 mic per ml. And it is less expensive. There is no bradycardia. It maintains the cardiac output. And it is more of an expensive drug. Phenylephrine is more expensive as compared to this. So it stands to be a more ideal obstetric vasopressor. And economics of using phenylephrine, it is 10 milligram per ml. Ephedrine is just 23 rupees, while phenylephrine is 230 rupees. Norepinephrine is 180 rupees. You do all the dilutions, you do not use up the drug, you just throw away the drug because your cesareans finish up within 20 to 30 minutes. So as we are fighting over ephedrine and phenylephrine, you find that ephedrine, phenylephrine and norepinephrine is going on to become the gold standard. So why exactly is it not a gold standard, phenylephrine? There is bradycardia, decrease in cardiac output with higher doses. If you use lower doses, you do not get good prevention against nausea and vomiting, and even the blood pressure is not maintained at baseline. Chances of arrhythmias are more reactive hypertension, and I've missed the slide.
Madam, as you are searching
and the serial dilutions, of course, they are both same with both the drugs, but of course it's a more costly drug, phenylephrine, and the computer controlled infusion system. That is the ideal for using prophylactic phenylephrine, which, if you calculate the cost, goes into millions of dollars. Thank you.
Thank you very much, madam.